Today's topic is something which all of us go through. Some of us go past this problem easily, but when the problem actually starts snowballing on us, that's when we realize how severe, what is in our hands and what we have to do. So all this knowledge has to be updated by each and every one of us, because it means saving two lives. So the topic today is on pregnancy induced hypertension, and I would like to go about this particular topic in a case discussion, so that we can cover everything as the case proceeds. We have a 35-year-old and a 34-weeker. No significant past medical history. Her BP when she was confirmed at 8 weeks was normal. She's now a 34-weeker. She's admitted in the hospital with a mild frontal headache and increasing swelling of her ankles is extending up to the mid-calf. Her blood pressure now is 170 by 100. A urine dipstick shows 3 plus of proteins. Now, what is the diagnosis? It's a no-brainer. It is a hypertensive disorder of pregnancy, and most likely it is preeclampsia. So what are the hypertensive disorders of pregnancy? They are chronic hypertension, preeclampsia, eclampsia, preeclampsia superimposed on chronic hypertension, and gestational hypertension, which generally, we get it on the latter half of pregnancy. So let us look at some of these definitions. What is chronic hypertension? Chronic hypertension is nothing but an essential hypertension or a secondary hypertension which existed even before the pregnancy. Whereas gestational hypertension, as I said, is generally seen on the latter half of the pregnancy, and it occurs after 20 weeks of gestation, and it returns back to normal within 3 months of delivery. Okay. And about 33% or 40%, for 30 to 40% of these patients can develop preeclampsia, which means what is the difference between a gestational hypertension and preeclampsia? So the International Society for the Study of Hypertension in Pregnancy, they have defined preeclampsia as a new onset of hypertension. When I say hypertension, I say the systolic blood pressure is 140, diastolic blood pressure is 90 or both, and accompanied by any of the following features. So what did we study? Patient, to call it preeclampsia, patient should have a high blood pressure, should have proteinuria, and should have edema, right? So now the present definition is that the patient can have any one or any two or all of them, right? So it can still be called as preeclampsia. So what are they? Apart from the blood pressure, the patient can have proteinuria, which is 1 plus or more, where the PCR, that is the protein creatinine ratio, is more than 30, and or the ACR, which is the albumin to creatinine ratio, is more than 8 milligram per millimoles, or both. Anyway, preeclampsia can present even without proteinuria. So please remember that proteinuria has to be present is no longer a diagnostic criteria. So the patient can have hypertension with liver involvement, hypertension, just edema. Patient may have hypertension with neurological issues. Patient can have severe headache or, persistent, some visual double vision or things like that. Still, it is called preeclampsia. So it doesn't mean that, all these three features have to be present. So with hypertension, you can have any of the features. So liver involvement can be there. So there are elevated enzymes, almost twice the normal. Neurological complications, which I said, like headache or scotomata, clonus, blindness, altered mental state, could be a stroke, it could be eclampsia, or hematological complications like thrombocytopenia or DIC, hemolysis, uteroplacental dysfunction, where there could be abnormal umbilical artery Doppler waveform, restricted growth, or stillbirth, And as I said, presence of edema is no longer a diagnostic criterion. So with all this, when will you call it as a severe preeclampsia? When the blood pressure is as high or above 160 by 110, which is measured twice, proteinuria more than 500 milligram per day, oliguria with urine output less than 400 ml over 24 hours, thrombocytopenia less than 1 lakh per cubic millimeter, when the liver enzymes are double the normal, or the patient is having epigastric pain for which no other reasons are accounted for, new onset of headache, unresponsiveness to medication, vomiting, visual disturbances, papillary edema, clonus, as I said, pulmonary edema, or presence of HELP syndrome. All this will amount to severe preeclampsia. There are some risk prediction tools for early diagnosis. And the NICE guidelines have come in to identify patients with who can develop preeclampsia. So what are they? The first and the foremost is the placental growth factor. So in these NICE guidelines, what they have done is they have incorporated multiple features. They have tested multiple, few things, and they have come out with guideline wherein they can identify those who can develop preeclampsia much earlier. So what are they? One is placental growth factor or other biomarkers, uterine artery Doppler measurements, and maternal risk factor. So this placental growth factor, what happens is it peaks at around 26 to 30 weeks of gestation. And beyond 30 weeks, it starts coming down. So this placental growth factor is decreased in preeclampsia. So what they find is in women who are presenting before 35 weeks of gestation, as in our case, growth factor is less than 12 picogram per ml. These are the ones, at the peak when you're testing between 26 and 30 weeks. When the placental growth factor levels are less than 12 picogram, then these are the ones who can develop, preeclampsia. And if you find that it is reduced at 35 weeks, you test it at 35, and if you find that the placental growth factor is less, that means you can't wait for more than 2 weeks before you can deliver this patient. So here is a patient in whom you have to hasten delivery. So if you need to give, steroids, or if you want to give whatever at that point of time, so as soon as you find that the growth factor has fallen to 12 picogram, no matter what the gestational age is, that means within 2 weeks, you have to deliver this patient. And the other thing is about soluble FMS-like tyrosine kinase. So what they call it SFLT1. So this is an antagonist to the growth factor. So, and what it does is, while the growth factor causes vasodilatation, and what it does is, it abolishes the intimal muscular layer of the placental arteries. So here what happens is, this is just the opposite. That is, this tyrosine kinase, it is an antagonist to that. And what it does is, it causes severe vasoconstriction, and with it, it can cause endothelial damage and increases the incidence of preeclampsia. So this is seen rising at around the same time when placental growth factor is rising between 20 and 35 weeks. And if you find that there is a high FMS-like protein, tyrosine kinase, to the plasma growth factor ratio, these are the ones whom you have to really, have the red card for them. And this FMS-like tyrosine kinase, that is SFLT1, can be determined by immunoassay also. And there are other prediction models which are available, like the PrEP-S, where you can find out early onset of preeclampsia, or the preeclampsia integrated estimate of risk. They are all validated prediction models and can be used at any time of the pregnancy. So all these also can help in decision making, particularly regarding when you have to admit this patient to the hospital. So there are some strong risk factors also which has to be considered, which can, you can see that the patient can develop preeclampsia. So what are they? If the patient already has chronic hypertension, or if the patient is obese with a BMI of more than 30, or pregestational diabetes, SLE, or if the patient has gone for assisted reproductive therapies, these are the ones who can develop preeclampsia by and large. What is eclampsia? Eclampsia is the occurrence of seizures in a parturient that may have no underlying pathology, and generally the signs usually remit by 6 to 12 weeks postpartum. And in eclampsia, the patient develops generalized tonic-clonic seizures with or without a rise in blood pressure and proteinuria, and it occurs during or after pregnancy with no other identifiable central nervous system pathology. So the etiology could be multifactorial. It could be because of vasoconstriction, ischemia, or vasogenic edema. There is no reliable test for predicting development of eclampsia, and the period of the highest risk could be antepartum and intrapartum, but almost about 40% you can have even postpartum. What is the pathogenesis of this entire hypertensive disorder? There are so many, theories which talks about reduced levels of nitric oxide. It could be because of immunological and genetic factors. But then that which actually gives, more, which can be more, what do you call, emphasis, is the one where the patient can have abnormal placentation. As such, the placental growth factor is reduced. There is abnormal trophoblast invasion at the time of placentation. And as I said, the growth factor is reduced, so there is failure to convert the uteroplacental bed into a low resistance, low pressure, high flow system, which means the musculoelastic portion of the spiral arteries does not disappear. Usually, when the growth factor is there, the musculoelastic portion of the spiral arteries, they completely disappear. That is why the entire uteroplacental bed becomes a low resistance, low pressure, and a high flow system. And that because a high resistance, high pressure, and a low flow system. There is an imbalance between the thromboxane and the prostacyclin. Thromboxane can aggregate platelets and vasoconstricts, and that it's in a very high level. And prostacyclin is something which can inhibit the platelet aggregation and cause vasodilatation, just the opposite of thromboxane. So the levels of prostacyclin is low and the levels of thromboxane is very high. So what happens? Because of intense vasoconstriction, there is a vascular endothelial dysfunction leading to increase in coagulation and extreme sensitivity to vasopressor. If supposing a vasopressor causes this much amount of vasoconstriction, here the sensitivity is so much that it causes intense vasoconstriction. That is the level of vasoconstriction which can occur. And I already told you what could be the reason about the SFLT1 and the plasma growth factor. And on the anatomical level, because of this, there is an increase in vascular tone and permeability, can lead to coagulopathy and ischemia. And because of the intense vasoconstriction, it can lead to ischemia of target organs like the brain, liver, kidney, and the placenta. And also, there is a reversal, as I said, of prostacyclin and thromboxane. So, what can that lead to? Increase in vasospasm, platelet activation and consumption with endothelial injury. So what happens? This widespread endothelial dysfunction may manifest as dysfunction of multiple organ systems, including the cardiovascular system, respiratory system, CNS, hepatic, renal, hematological. Every system is involved because of this endothelial dysfunction. The endothelial damage leads to a capillary leak that can manifest in the mother, rapid weight gain, non-dependent edema of the face or hand, can cause pulmonary edema and hemoconcentration. When the placenta is diseased, it can affect the fetus via a decreased uteroplacental flow, and this decreased perfusion can manifest as non-reassuring fetal heart rate, low scores on the biophysical profile, oligohydramnios, and IUGR. So let's look one by one. What happens to the fetoplacental unit? As I said, because of the generalized vasospasm and the reduced intravascular volume, there is placental insufficiency, and because of that, there can be diffuse placental thrombosis, inflammatory decidual vasculopathy, and trophoblastic invasion of the endometrium. There is an intraplacental hypertension can lead to placental abruption, fetal growth restriction, and premature delivery, all of which can lead to IUF. So that and oligohydramnios. What happens to the cardiorespiratory system? Patient develops hypovolemia because of vasoconstriction. There is an increase in SVR because of that. And the load on the heart can lead to left ventricular hypertrophy. Then there is increased sensitivity to catecholamines, sympathomimetics, and oxytocin. The hypertension is very, very labile. And because of that lability, patient can develop congestive cardiac failure. And as I said, because of the increased capillary permeability, patient can develop pulmonary edema and ARDS. And because of increased total body water, patient can develop airway mucosal edema and tongue edema. And what could be the cause of pulmonary edema? Pulmonary edema can be due to cardiac or it could be non-cardiac. Cardiac, as I already said, patient can develop diastolic and systolic dysfunction, congestive cardiac failure leading to pulmonary edema. Non-cardiac causes could be because of an increase in capillary permeability, a decrease in colloid osmotic pressure leading to fluid over. So, which means these are the patients you have to enhance your monitoring to get a better outcome. Hematological, what are the things which can get affected in the blood? So you can have a prolonged bleeding time. Platelet dysfunction like thrombocytopenia can occur. DIC can occur because of microvascular endothelial injury. The thrombocytopenia can be because of autoimmune mechanisms of platelet destruction. And if there is platelet dysfunction, the larger the platelet dysfunction, severe is the disease. So you need to do PT, PTT, fibrinogen levels, and the entire DIC profile. The kidney can be affected, both the glomerular function as well as the tubular function can get affected. Patient can have oliguria, ARF, a rise in BUN, serum creatinine, which means you have to be very, very careful with the fluids. You can't just overload this patient. Patient can develop hepatic functions is abnormal. There is rise in the enzymes. Patient can develop epigastric pain. And if you find a pregnant patient coming with severe epigastric pain, in the casualty, you know that you're dealing not with the patient in labor, but a patient who has developed, HELLP syndrome. So this could be because of tension on the capsule of the liver, caused by edema or intrahepatic hemorrhage. Presence of hepatic hemorrhage is associated with a very, very high level of mortality. So, patient has developed HELLP syndrome. And what is HELLP syndrome? HELLP syndrome is hemolysis, elevated liver enzymes, and low. What happens to the central nervous system? As I said, there is intense vasoconstriction in all the organs, and so is the cerebral vasospasm. So, the ischemia can lead to disrupted blood-brain barrier or cerebral edema and cerebral hemorrhage. The patient presents with headache, like a frontal throbbing migraine like headache, coma, hyperinflexia, focal motor deficits, and visual disturbance like scintillation and stomata and cortical blindness. Here I would have to tell you that I myself suffered during my first pregnancy. I was not diagnosed with severe hypertension, but probably, 1.5 months before the delivery, I developed severe headache and I was literally, obtunded. When my mother used to come and wake me up, I used to tell her, in fact, scream at her, tell her, don't disturb me. I want to sleep. Don't disturb me for food. Don't disturb me for anything, and switch off the lights. So I didn't want to see light because that was hurting my vision, and I had severe headache, and probably I was hypertensive. And next day morning, this happened for over a period of 4 5 weeks. My mother was very worried, and unfortunately, I was registered with obstetrician who was extremely very well known, and her we could get her appointment only 3 months later. So she was saying we should go to someone else now, but I was just not willing to listen to her. And then the next day morning, I woke up with blindness. Luckily, it got relieved within an hour. But this is what happens here. For me, I was lucky to get, a reversal of blindness. But remember, these are the patients who can permanently turn blind. So, what are the investigations you have to ask? Urine output, you have to find out proteinuria, urine PCR, you have to do entire blood count, including renal and liver function tests. And if the patient is on magnesium, you have to do serum magnesium, serum calcium, because, patients who have hypocalcemia are prone to develop, preeclampsia, much higher chances of getting preeclampsia than those with, normal calcium levels, grouping, cross matching. And you have to do a cardiograph, the ultrasound to know the fetal growth, amniotic fluid volume, uterine artery, Doppler blood flow, all this to assess the placental blood flow. So, what will be our treatment goals? First and foremost, you have to avoid the CNS irritability and prevent the convulsion, for which, my friends, remember it is magnesium sulfate. Don't forget this drug. The minute you think there is headache, irritability, obtundation, or whatever, any sign of CNS irritation, you have to give magnesium sulfate. Magnesium sulfate is an anticonvulsant. It reduces the irritability at the neuromuscular junction. Second important thing is restore intravascular fluid volume. As I said, there is intense vasoconstriction, so the fluid volume is much less, so the urine output will be less. You have to strictly monitor urine output. And CVP, I would not give so much of emphasis to CVP, but remember, CVP, you have to maintain at least about 6 centimeter of water. Normalize the blood pressure. In fact, magnesium sulfate helps in actually normalizing the blood pressure, apart from your other antihypertensive agents like labetalol, hydrolazine, nifedipine, etc. So it has a direct vasodilating action on the smooth muscles of the arterioles and the uterus. You have to correct the coagulation by giving platelets, FFP cryos, and also take a decision regarding the timely delivery, and that will depend upon the gestational age, fetal lung maturity, and the severity of the disease. As I said, there are some prediction tools. You can use those prediction tools and think about the delivery. So, coming to certain prevention, how can you prevent? There are some studies to say a low dose aspirin can prevent preeclampsia. Again, this was a class study which was done in a large population, wherein the aspirin, which is known to reduce the thromboxane production, caused a small reduction in the incidence of PIH. As I said, the CAP trial, that is calcium and preeclampsia trial, they also found that a calcium has a small role in reduction of preeclampsia. Again, a folic acid trial called the FACT trial also was done, and they found that beyond the first trimester, it does not help to prevent. But in that first trimester, if you have taken adequate folic acid, then that can help in prevention of preeclampsia. The first is to reduce the blood pressure to less than 140/90. And remember, all the drugs which you are using to reduce the blood pressure is only to reduce the myocardial and the cerebrovascular complications, but it does not alter the course of PIH or the fetal well-being. Now, going back to the case, she is reviewed by the junior obstetrician and the multipara monitors attached for continuous monitoring. CTG monitoring is commenced. You have placed a cannula and the blood values are sent to the laboratory. Now, what is the treatment now you have to give? Now, you have to ensure that the blood pressure is brought back to normal. 170 by 100 was the blood pressure. Now, you have to bring it down to 140 by 80. So, what antidiuretics are you going to give? Avoid diuretics. Remember, we already have hypovolemia. So, you cannot give diuretics. The one with methyl dopa, alpha methyl dopa, has minimal side effects that can be considered. But what should be considered as the first line of treatment is a combined alpha beta blocker like a labetalol, or you can also give metoprolol or oxprenolol. Calcium channel blockers like nifedipine can be given orally 10 to 20 milligram every 30 minutes. You want to control the blood pressure. Sublingual administration should not be given because that can lead to resistant hypotension in the mother and can lead to fetal distress. Prazosin is second line. Hydralazine causes maternal hypotension and fetal distress and is also considered a second line only if nifedipine and labetalol are not working. And alpha adrenergic receptors inhibitors, which are actually used for chronic hypertension, they need diuretics for salt and water retention. And if possible, please avoid ACE inhibitors and angiotensin 2 blockers are associated with oligohydramnios, stillbirth, and neonatal renal failure and not used. The BP is not controlled on antihypertensives, which you have given. Now she complains of headache and she's seeing flashes of lights. She's found to be hyperreflexive, and now she's already given a dose of labetalol, 200 milligram. Her BP is being monitored. Her BP is still at 170, 120. Now what is to be done? See, this is an uncontrolled hypertension. Now, when you start, you give a small fluid bolus. See, because here you can't even give large fluid boluses. So monitored small fluid boluses have to be given because the patient you want to avoid uteroplacental insufficiency, and some of the antihypertensives which you are using can cause vasodilatation and there will be a sudden fall in blood pressure. So first you give a small fluid bolus of 250 ml, give IV labetalol at about 40 milligram increments every 15 minutes, start giving. And what is the contraindication for labetalol and when you should use nifedipine? When the patient has bronchial asthma. And if the BP is not controlled with the maximum dose which you can give is about 220 milligram per hour. So if that is achieved and still the blood pressure is not coming down, then you can think of hydralazine bolus, 5 milligrams slowly, every 15 minutes you can give. Check the blood pressure every 20. If the maternal tachycardia is more than 130 beats per minute, then you have to stop it. At this point of time, consider magnesium therapy in these patients. So magnesium should be used if you have even a small iota of doubt that this patient is having neurological symptoms. It is used as prophylaxis for severe eclampsia and as a treatment of eclampsia. And especially in the villages or any low resource area, if the patient has any two features of severe preeclampsia, which I mentioned, you please start magnesium. Don't worry whether the patient is having any CNS features or not having. It's better to be proactive than to worry about it later. So the loading dose is about 4 to 6 grams followed by an infusion of 1 to 4 grams per hour with a goal to achieve a serum concentration of about 5 to 8 milligram per deciliter up to 24 hours following delivery or 24 hours after the last seizure. So those things about the plitratrazine, giving it intramuscular, all that can also be done. But when it is always better to give magnesium sulfate IV in these patients. Recent update is magnesium sulfate infusion can be stopped about 12 hours postpartum in a stable patient. Remember, it may take up to 3 months for the blood pressure to come down to normal, but you can stop the magnesium up to 12 hours postpartum. So, what all will you monitor when you're giving magnesium sulfate? You'll monitor urine output, deep tendon reflex, respiratory rate, oxygen saturation, and the serum concentration, because you have to avoid toxicity. That patient can develop headache, nausea, vomiting, flushing, and weakness. And in toxicity, you have loss of deep tendon reflexes like the patellar reflex. Patient can be drowsy, the respiration will become slow, and you can have a cardiovascular collapse. So, what is the treatment for magnesium toxicity? Give IV calcium gluconate. So, what are the other implications of magnesium sulfate? It has got direct vasodilative property, may improve the cerebral ischemia and the uteroplasmic blood flow. And it has, as I said, it also brings down the blood pressure. It decreases the uterine tone, increasing, and that can increase postpartum bleeding, remember. So, patient with PIH on magnesium can develop bleeding, postpartum bleeding. Remember that. Yeah. It can augment neuromuscular blockade by inhibition of calcium-mediated presynaptic release of neurotransmitters. It also has analgesic effects. And the neonatal effect is the child can develop hypotonia and respiratory depression. And if magnesium sulfate is toxicity is there, or if for whatever, if the patient has renal failure, then you can even use IV phenytoin, or now you can use injection levocetine. Steroids are useful because of the endothelial damage, and it has to be used in HELP syndrome. So here in HELP syndrome, it decreases the damage of the hepatocytes and platelet consumption. Glucocorticoids can be given every 24 to 48 hours. It also improves the fetal maturity, lung maturity, and maternal platelet count. Dexamethasone 10 milligram every 6 hours for 2 doses, followed by 6 milligram every 6 hours for 2 doses can be given, or betamethasone also can be given twice daily. Now, a bolus of labetalol was given, followed by infusion of labetalol, then a liter of ringalactate was also given to this patient. BP, oxygen saturation, heart rate, respiratory rate was monitored. CTG was monitored. And now they were thinking, now it's time that, now that the BP is slowly coming down, now we have to go for a delivery. And well, that plan was going on. Suddenly, she develops a grand mal fit. How should you manage this fit? How will you manage? Will you give propofol, midazolam at this point of time? No, you should be very careful. This fit is nothing but an eclamptic seizure. There could be, you have to rule out other things, but by and large, it's an eclamptic seizure. It could be because of pre-existing epilepsy or intracranial event like subarachnoid hemorrhage, or it could be vasovagal, or it could be hypoglycemia. But now, in this patient, you have to consider this as an eclamptic fit. And what will you do at this point of time? Quickly shift the patient to a left lateral position, call for help, do your ABC, airway, breathing, circulation, have a high flow oxygen facial mask, obtain an IV access, and give magnesium sulfate. Friends, don't forget, here it is not propofol, midazolam. You have to give IV magnesium sulfate. Monitor ECG, BP, respiratory rate, oxygen saturation. Check the blood sugar. Okay. Now, a bolus dose of magnesium is administered. She's commenced on an infusion of magnesium. Her respiratory rate, reflexes are checked regularly. Now she is on left lateral position. Now, what about the delivery now? Now you have to deliver, right? So you can think of vaginal delivery if the patient is stable on all these antihypertensive medication and the laboratory values are okay, and there is reassuring fetal tests. Remember, it's always better to have this patient shifted into a tertiary care hospital where you can do some close monitoring. Delivery is now induced when the fetus is more than 37 weeks of gestation and there's lung maturity, there is a favorable cervix, or if the maternal or fetal duration occurs despite the conservative management. And if the patient is If there is extreme prematurity or fetal compromise, immediately go for a cesarean section. And when else will you run for a cesarean section? When there is severe hypertension that persists for more than 48 hours and not coming down despite your maximal treatment, progressive thrombocytopenia, liver dysfunction, patient has come to the casualty with, epigastric pain, and there is HELP syndrome, progressive renal dysfunction, premonitory signs of eclampsia or fetal jeopardy, you have to go quickly for a quick LOCS. So supportive management will be, supportive management will be seizure prophylaxis, BP control, and then immediate delivery. You have to deliver, give blood products if needed, steroid for fetal lung maturation and plasmapheresis, and close surveillance. All this when the patient have had HELP syndrome. So platelet transfusion should be given to those whose platelet count is less than 20,000 per cubic millimeter. And when you're finding bleeding through punctured sites or there is ecchymosis, about 6 to 10 units of platelets should be given before trying to intubate the patient for cesarean. FFPs and packed red cells should be given, especially in those with coagulopathies and DIC. Fluid restriction should be there unless it is associated with maternal hemorrhage to reduce the chance of fluid overload and pulmonary edema. The CTG now demonstrates repetitive and severe fetal heart rate deceleration. Now she is reviewed by the senior obstetrician who feels that this patient has to be taken up immediately. What is the most appropriate anesthesia technique? Would you want to give GA or you want to give regional at this point of time? Now, if there is no, hematological issue, regional anesthesia should be encouraged in all these high-risk patients. So what are the anesthetic concerns? One is, how am I going to handle the pain if we are looking at vaginal delivery? Regional anesthesia should not be considered, as I said, if there is any coagulation issue or if the patient has raised intracranial tension. And if you're considering GA, then the deterrence you have to worry about is patient is on magnesium or the presence of difficult airway because there is large tongue in these patients and there is facial edema, airway edema. So all these are concerns for us. Regional anesthesia, you can give spinal, epidural, CSE. All this can be done. What are all the, what are the advantages of for regional in these cases? Preoperative evaluation has to be perfect in these patients. You have to optimize the patient. Look for any stridor, edema, dysphonia, dyspnea, because you have to rule out upper airway and pulmonary edema in these patients. Is there any change in the urine output? Is there any coagulation status? Is there any problems with the coagulation status? Is the patient on magnesium infusion? And if the patient is on magnesium infusion, coagulation profile every 6 hours has to be done. So in the presence of low platelet count and coagulopathy, there could be, if you attempt a spinal or an epidural, you can end up with an epidural hematoma or spinal cord and paralysis of the patient. Remember, so you don't attempt at this point of time. And in the presence of HELP syndrome, remember, if the platelet count, if you have treated the patient and if the platelet count is above 75, you can give regional. But below that, please do not attempt a regional. And if so, you correct the coagulopathy and then you can give. Labor analgesia can be given in these patients if there is, as I said, no coagulation problems with these patients. And in fact, it will facilitate the progress of the patient and it will benefit the patient because it can control the catecholamines and can control the blood pressure. It increases the intervillous blood flow and relieves the uteroplacental ischemia in these patients. And apart from giving good pain relief to the patient. If the central neuraxial blockade is contraindicated, remember nowadays we have remifentanil and that can help if you can give it as PCA, it will definitely help in reducing labor analgesia. Don't think that the patient can be, it can cause central nervous system depression or, hypoventilation and things like that. It is, the kind of central depression and hypoventilation with remifentanil is very, very few. And even if it occurs, it can occur only for 1 or 2 minutes. If you can stop the drug, immediately the patient recovers immediately. So don't worry, remifentanil is an excellent drug. You can give labor epidural with ropivacaine in these patients. You have to step up your monitoring. In these cases, you have to go for an arterial line, CVP line, etc. And general anesthesias can be very, very challenging because of airway, where you have to maximize oxygen delivery to the mother and fetus, and you have to blunt the hemodynamic response. So you have to, the risks is at the time of induction intubation, you can have a very high blood pressure because the blood pressure can be very labile. You have to obtain the intubation response of these patients. Patient can have difficult airway. You can have a loss of airway because of pharyngolaryngeal edema, aspiration, and at this point of time, you have to put in an LMA, and the pharyngolaryngeal edema can be very dangerous to these patients. And the patient can have aspiration also. Remember, you have to have small size endotracheal tubes in your trolley, less than about 6.5 to 5.5 diameter, and you have to attenuate the hypertensive response with labetalol, magnesium, NTG, lignocaine, whatever suits you well. And then have facilities for neonatal resuscitation in these patients, especially if you have given magnesium or you've given opiates or remifentanil. Remifentanil can avoid this problem because the effect by the time the baby is delivered, the effect of remifentanil is over. So usually remifentanil is very useful. Isoflurane can cause vasodilatation, or you can use sevoflurane. Remember, the magnesium can potentiate the effect of neuromuscular blockers. You have to monitor neuromuscular monitoring. Avoid ergometrin in all forms. Give only oxytocin to this patient. Patients have to be extubated after full return of consciousness and airway. Now she is transferred to the theater. She is given, GA. The baby is delivered. Anesthesia is uneventful. Now she is not waking up. Now what is the cause? The cause of delayed awakening could be because of excessive anesthetic agent, excess opiates, or inadequate reversal, respiratory depression due to magnesium toxicity. It could be hypoglycemia. Most importantly, check the pupils. If there is unequal pupil, it means the patient has developed intracranial hemorrhage, and that's when the patient will need to go for a CT scan. Fortunately, she wakes up after 30 minutes and makes an uneventful recovery. What will be the ongoing treatment? Post-operatively, remember, she has to be in the ICU for about at least 48 to 72 hours. For 12 hours, the magnesium therapy will continue. Laryngeal edema may worsen, remember, so re-intubation has to be, you have to be prepared for a re-intubation here. Antihypertensive therapy should be continued, and anticonvulsion therapy also should continue in these patients. Avoid fluid overload, maintain urine output, give her adequate pain. So friends, preeclampsia poses a clinical challenge requiring considerable skill and experience on the part of anesthetic. Vigilance and prompt action leads to better outcome. Thank you very much.